Thank you, committee. There is very honor and pleasure to stand in front of all you. I think this is a historical moment. We can discuss something topic. So we realize this topic is still happen until now, pro and controversies on hypothermia therapy. It's better we start with a history of hypothermia. We can find in GNS 2019. Hypothermia has been used of and for clinical purposes since 3 BC, and I think we is promoted by Edwin Smith. And this is our tribute to Dr. Temple Fay. He's a modern therapy doctor to use in several cases in cerebral trauma and published in 1945. Controversies, contradictory, pros and cons expressed in several journals and several publications. Also in the last JAMA, we found the polar randomized clinical trial. They proposed there's no significant result for hypothermia therapy in severe TBI. But fortunately, in the other side, in 2018, there's a tragedy with Schumacher. So Euro team and Edinburgh team used hypothermia to treat this patient. So in 2018, also in the textbook, the new textbook, hypothermia therapy is still used in several cases in TBI and spinal cord injury. 5 years ago, therapeutic hypothermia therapy is published, explores, and we need a journal. So Marian published a special and focus for the therapeutic hypothermia manuscript. So many discuss and many question and answer in this journal. And the new latest textbook, hypothermia therapy is a part of temperature management and neurosurgical critical care. So wonders of medicine, this author said like that because we approach in biomolecular hypothermia therapy could improve signal pathway, improve gene regulation, and improve microstructures. That we know that hypothermia could be reached in every phases of TBI. This is the acute, subacute, and chronic phases. So we call it hypothermia is powerful neuroprotector. So we still research until now and still going on about 300 and 300% next week. So we support also with Professor Narayuki Hayashi. He is the editor of Brain Hypothermia Treatment textbook. So in 2016, Professor Narayuki retired and replaced by Professor Maeda in Nihon University. So during we explore the hypothermia therapy in severe TBI, so we can explore an aspect biomolecular that we propose that TBI not only two phases, primary injury or secondary injury, but we can find tertiary brain injury. Tertiary brain injury is important for us for the prolonged complication like Alzheimer's, Parkinson's. So hypothermia therapy can reach in stage 1, stage 2, and stage 3. We call it tertiary brain injury. This is our paper for the next published in February 2020. We presenting hypothermia therapy could approach the microglia prolonged activation, could depress, down-regulation the activities of microglia. This is several journal also state that moderate hypothermia therapy stop or inhibit activation of microglia. With Professor Polderman from Pittsburgh, we presenting a paper in Japanese Society Intensive Care Medicine last year. And Professor Polderman is also the pioneer in the phases of the treatment of the methodologies of hypothermia. We have 3 stages. This is inductions, maintenance, and rewarming. This is our publication in several journals. So we can improve that hypothermia therapy in outcome, not only DCS, also in full score. And our research state that hypothermia therapy can decreases MPP9 as a degradable enzyme to matrix, and also decreases TNF-alpha protein, which is presented in Neurotrauma Congress last year in Toronto. Is the core of the pro and controversies is a misunderstanding in responding to issues that controversies, as some colleagues that say there we need homogeneously designed statistically clinical methodology to improve outcome. This is important for us to protect the bias in systematical review. Heterogeneous is inconsistent. This is the problem. The hypothermia is not function in the severe TBI. This is also in chapter 2 of controversies. The researcher said that changing study design, homogeneous patient, and I think a sensitive outcome depend on proper methodologies. So as researchers, we should stand in impartial position, must be proven by the research. So early protective hypothermia is not only reduces MPP9, it remains a simple option for multimodal therapies for in severe TBI. This is the new publication that we proposed. We use research together in several countries. So we have a question: is there still a place for hypothermia therapy in the management of traumatic brain injury? For the time being, we still waiting the golden bullet to treat severe TBI. Our college in Korea, we proposed all-in-one treatment. This is no one modality, but multimodality treatment for severe TBI, also hypothermia therapy and the compressive craniectomy. Thank you, and see you in next ICRAN 2022, Manado, Indonesia. As president of the next host, please come to Indonesia. Thank you.